Hello and welcome everyone. It's 7 o'clock, so I'll start. I think I've got 4 members, so we'll call it. Welcome to July Health in Hackney. Just to go through a few the usual items of housekeeping. It's being live streamed, it's being recorded. Members of the press will be watching. Giles, can I ask you to turn your microphone off? Is that okay?
Yeah.
Just on that, if everyone can keep their microphones off until speaking, that would help to avoid feedback. Keep cameras on if you can. Raise your hands to get my attention. There's something going on with the software with Google not having grid view, so I don't quite have everyone here, but I have most people in front of me. And so we'll take it like that. In terms of apologies for absence, I've got lateness from Councillor David and apologies from Tracy Fletcher. Declarations of interest, I don't think there are any. Councillor Snell, your regular one is no longer apposite. No, thank you. In terms of, I haven't been notified of any change to the order of business. I think what I'm going to do is, rather than do a long list now of who's here, I'm not going to waste time doing that, but before each item I will do an introduction. So with that, I will go straight on to item number 4 if I can, which is the Homerton Hospital and the soft services contract. I've already said to the speakers, we've got Phil Wells here, who's the Director of Finance at the Homerton. We've got Thomas Nettle, who's the Director of Workforce at the Homerton. We've got Naomi Byron from Unison, Lola McAvoy from the GMB, and Michael Etheridge from Unison. Welcome all and thank you. I was going to ask the union representatives to speak first for no more than 5 to 7 minutes. Then followed by the Homerton for 5 to 7 minutes, and then we'll open up for questions. Can I say at the outset, congratulations to Homerton on the outstanding CQC. We're immensely proud of you. I think whilst at the same time we can be incredibly supportive and proud of you, there will be areas where we also want to challenge you, and this is one of them in terms of the soft services contract. Can I ask everyone to just be respectful, because I can imagine in a debate like this, emotions could possibly get quite high, so if we could retain that. And thank you for everyone coming. Just to give a very brief overview, because I know a number of people are watching this live on the YouTube channel, is that the Homerton has outsourced for a while now what's called its soft services, dealing with catering, security, cleaning, portering services at the Homerton. There's about 200 full-time equivalents there. The contract is coming up for renewal. The Homerton is minded, it appears at the moment, to seek a 5-year new contract with the provider ISS. Concerns have been raised about the length of that vis-a-vis insourcing it. I think there's an appreciation that the Homerton couldn't go straight to insourcing, but a much shorter contract and allow for work to be done on insourcing. There have been concerns raised about whether there's been an equality impact assessment. There's been concerns raised about the VEET nature, which is the contractual mechanism of which the contract is still being renewed. And there's also concerns with respect to the lack, or what has been the lack of occupational sick pay for about half of those 200 workers, or thereabouts, who have joined ISS since 2015, who, as I understand it, don't get any right to sick pay for the first 3 days, and then on day 4 would get statutory sick pay, and that is around £92 a week. They would otherwise normally be on somewhere between £80 or £100 a day. So that's obviously a substantial reduction. and the issues that have arisen in relation to that are obviously particularly around the COVID situation in terms of ill people coming into work in an infectious environment and the risks there, but also in terms of the fact that 72% of that 200 strong workforce is from ethnic minority community groups, and the concern is that we're locking in disparities by re-signing this contract. So with that overview, I'll hand over now to those from the unions. So who would like to go first? Is it Michael, Naomi, or Lola? Who's going to kick off?
I'll start, Ben.
Thank you. Off you go.
Thank you. Just a quick note, Naomi's still trying to get in. I've passed on your message. She's having some trouble logging on, but I've asked her to log off and try again. So thank you. So hi, everyone. My name is Michael Etheridge. I'm a full-time officer for Unison, supporting the Homerton branch. The proposed new contract is absolutely devastating for our members. They feel betrayed by a trust that tells them they are part of one NHS family whilst failing to demonstrate this. Unison reps have been making the case to management for many months for a substantive improvement to their terms and conditions. To be clear, we oppose the outsourcing of these services in the NHS. It's bad for workers and bad for the community the hospital serves. It drives down terms and conditions across the public sector. Cost reductions may seem attractive, but ultimately they're passed on to workers in forms of casualisation, intensification of workloads, lower pay in terms and conditions, and cutting corners with health and safety. It's also bad for the quality of the service. For instance, research from the University of Oxford evidenced the link between outsourcing and higher rates of MRSA in hospitals. Retention rates are lower amongst private contractors due to poor employment practice, resulting in a loss of expertise. And outsourcing creates barriers in the workplace. It creates a two-tier workforce. Morale is particularly low amongst outsourced staff. Unison members have reported to reps they feel like second-class citizens, that there's a class system in the hospital. The fact that they are majority Black and ethnic minority workforce makes this all the more shameful. This view is supported by evidence across the sector, laid out in various EHRC reports. Our members employed by ISS are responsible for stopping the spread of infection in the hospital. They transport patients around the hospital. They make sure patients, staff and visitors are well fed. They keep the hospital secure and safe. They're essential frontline services, frontline workers without whom the hospital wouldn't run. Their contribution is no less valuable than NHS staff, and yet the Trust chooses to place relatively less worth on it. And our members live the consequences of this choice every day. So ISS, the company, has reported hundreds of millions of pounds worth of profit last year. They did so off the backs of our members, who they refused to pay proper sick pay or the London living wage. Homerton Unison has found ISS to be an irresponsible employer. For example, they agreed to pay the London living wage as part of the current contract and did so at the start, but then pay rates fell behind the London living wage between 2017 and April 2020, leaving our members owed thousands in back pay. This issue remains outstanding, and a new contract with ISS would represent an endorsement by the Trust of this immoral practice. I was going to hand over to Naomi to make some comments as well. Has she been let in the room yet?
I think there's a few challenges there whether she might join in audio. Does Lola want to say anything in the interim?
Yeah, maybe that's a good idea.
Hi, thanks, Michael. My name's Lola McAvoy, and I'm a GMB organiser for the NHS and for contracted out workers in London. I think for us at GMB and at the Homerton, the big issues that we've got around this contract are about the timing and the process, which is why we're here tonight to present to the Scrutiny Committee, because we feel that it's wholly lacking in any public or official scrutiny. What that means for the choice of a 5-year extension and the actual legality of a VEET process in this instance, what that says to our members and our workers at the Homerton Hospital, who are key workers, essential key workers, who have been frontline throughout this pandemic and before for a long time, about their role in the hospital and in Hackney, and about the disrespect that this process and that this locking of them into 5 more years of, frankly, below par and poverty-inducing terms and conditions actually says about how we as a borough value these people. And then finally, about why we are not taking the serious concerns raised about the disproportionate impact that COVID-19 has had on certain ethnicities who are overrepresented in the facilities management contract at the Homerton, and specifically why anybody would try to extend a contract against the instruction of NHS England and the trade unions at a national level, which would be so contentious when there'd been an ongoing campaign and multiple complaints about the provider ISS from both trade unions about bullying, harassment, a refusal to pay sick pay to people with very severe illnesses, despite despite us now coming to light that they actually have an occupational sick pay scheme. They refused to pay it and looked somebody in the eye and told them that despite them having a very serious diagnosis, that they would be absolutely not given anything other than statutory sick pay, which is a real term cut of 70% of their normal weekly wages after 3 days unpaid. So if those things do not flag up ISS as an irresponsible and wholly inadequate employer within our public services, which in turn should have influenced the decision to take out a VEET, which when we saw independent legal advice from a procurement lawyer in the NHS, they told us that a VEET should only be used in the very specific circumstances that there were absolutely no problems whatsoever with a contract. That's the only reason you can extend using VEET, is if the contract has been absolutely brilliant and both parties are totally supportive of the performance of the provider. And I just can't, I'm really interested and here for this meeting to find out why how what we've experienced, what our members have experienced at Homerton, and how that actually fits with the trust decision.
Thanks, Lola. We've got a couple of minutes left. Naomi's now joined us. So from the opening remarks from the unions, Naomi. And Naomi, you can't quite hear you. Your audio on the screen. That's it. Got you.
Okay. Thank you for having us. Thank you for inviting us. COVID-19 has reminded us all what work is essential. During the pandemic, ISS staff have faced unprecedented levels of stress. They've all stepped up to the plate, but despite this, Unison has had to fight hard to ensure that ISS does not treat their staff unfairly, including negotiating sick pay for those self-isolating and shielding. Contrary to this agreement, ISS members have been called to formal sickness hearings for self-isolating. The Clap for Carers initiative celebrated not just the nurses and doctors, but also low-paid ancillary staff. Many have been shocked to find out that these key workers remain outside the NHS system, locked into a privatised race-to-the-bottom economy built on inequality. Whilst equality remains a principal philosophy of the NHS, outsourcing entrenches structural inequality within our public institutions. The brutal murder of George Floyd has triggered a global conversation on racial inequality. Unison will always challenge racism in the NHS, including mechanisms of structural inequality such as outsourcing. 77% of ISS staff who work at Homerton Hospital are from Black and/or minority ethnic communities. As such, the two-tier workforce disproportionately harms Black and minority ethnic communities, keeping them in low-paid jobs with poor working terms and conditions, with little opportunity for progression, further exacerbating social inequalities in our society. We know from the ONS that security guards are more likely to die from COVID-19 than any other profession. As a majority BMAE workforce, they are at increased risk and yet receive less reward. The Trust has an opportunity here to make a statement to these Black and minority ethnic workers that they are as deserving of dignity and respect as their white colleagues, and that as they take the same risk, or arguably more, they deserve the same reward. This is an opportunity for the Trust to show that Black lives matter. Outsourcing is not just bad for race equality, it compounds labour market inequalities of age and gender too. Older workers are disproportionately represented in these roles. Gender segregation by role is pervasive with few opportunities for progression. 80% of cleaners are women, while 84% of security guards are men. We acknowledge the Trust's goal to secure continuity of service at this time. However, this cannot be at the expense of the well-being of an underpaid majority BME workforce forced to attend work while sick just to pay their rent and bills. We also recognise the financial landscape the Trust finds itself in. Although the Trust has reported a healthy surplus year on year, Unison has been calling on the Trust not to sign a new 5-year contract for the reasons we've laid out. Instead, we request they use the existing provision within the current contract for a very short extension so that we can fully explore the in-house option. Within this contract extension or any new contract, the key for Unison is we want to see parity with NHS terms and conditions.
Thank you, Naomi. So can I now go to those from the Homerton? I don't know who's going to go first. I mean, in some of the themes that have been raised, if we can sort of just try and get some sort of answers as to why we're not going for a much shorter period of contract to allow insourcing to happen in the medium term. What about the occupational sick pay element? Why the use of the VEET? What about the racial disparity with respect to 72% or thereabouts of the workforce being from ethnic minority communities? So I don't know who wants to go first.
Thank you, Chair. I was going to make a few remarks first, and then I think Tom will follow. Good evening, everybody. I'm Phil Wells. I'm the Finance Director at Homerton. Chair, could I first just reflect quickly on your opening remarks about Homerton's recent CQC inspection, and thank you for your recognition of that. We're absolutely thrilled at the Homerton to have been recognised as an outstanding site at the Trust. That's a fantastic achievement, and a tribute to the entire Homerton team for the hard work that they've put in. Thank you too for inviting us. Tom and I are glad to be here. But also I wanted to say thank you to Naomi, Michael, Lorna and Lola for the dialogue actually that we've been involved with over the course of the past few months. I think Tom and I and all of the executive and the board recognise that their role is an incredibly important one, and a really important part of all of this process, and their representation of the workforce, whether NHS or outsourced, is a very vital part of the way we operate within the NHS. So I want to say thank you to them for all the work that they've been doing. As you said, soft FM services have been provided at the Homerton on an outsourced basis for a number of years, most recently by ISS. That contract expires at the end of September. The board have chosen to recontract with ISS for a further 5 years under the negotiated procedure of the public contract regulations, and published a VEET notice to that effect at the beginning of June. That VEET notice effectively sets out the rationale for the extension, the recontracted period, and the decision reflects both a general uncertainty in the soft FM market, but also the additional risk and uncertainty resulting from the economic fallout of leaving the European Union, as well as what we now know to be quite a devastating effect on the global economy, but the UK economy too, of the recent health crisis. The most important thing in terms of the contract, though, is to ensure that we have a soft FM service that delivers a clean hospital, a safe working environment for all of our staff, and crucially for our patients. And as you said, that site is now rated outstanding. ISS have been a part of achieving that rating, and we're incredibly grateful for the work that they do. And service standards from them over this contract have been really rather exceptional. All of the technical audits that are undertaken day in, day out at the hospital are of a very high standard, and the ISS team put in a great amount of effort to make sure that's the case. And I think in particular the MRSA rates at Homerton are among the lowest. So we're very proud of that record. And in particular the work that the Homerton team with the ISS staff have been doing through the course of the recent pandemic. We've been negotiating this new contract with ISS for a considerable period of time. It is largely a like-for-like replacement for the current service that we get. There are a small number of changes of a commercial and technical nature within the contract, but we have absolutely recognised from the outset that there are two fundamental issues that are not addressed in the current contract and that we are working with ISS to remedy. Those are the two that we've heard today from our union representatives and colleagues on sick pay and on the London Living Wage uplift. I'm really optimistic from the conversations and dialogue that I've been having with ISS that we will reach an agreement with them on that. We are not there yet, and it would be improper of me to obviously go into the details of that negotiation, but we are, I think, within the touching distance of getting to a place that gives us the sorts of recognition that is being talked about. And I'd say that we are completely determined as an executive team to get to a point where we have a negotiated contract with ISS that recognises the contribution that the ISS team make to the success of our hospital. And Tom, I don't know if you want to come in at that point and make a few comments.
Thanks, Phil. Hello, everyone. I'm Tom Littell, the Director of Workforce and Organisational Development. Work alongside Phil on the executive team at Homerton University Foundation Trust. Phil said much of what we both wanted to say as opening remarks. I would just add a couple of other points. The first is that we have been engaging in meaningful discussions with union colleagues over the months during which we've been talking about the contract. I've been speaking with Lola regularly on an informal basis. Naomi and I have had discussions when we've seen each other in the organisation. I would absolutely acknowledge there are meaningful disagreements between union colleagues, including Lorna and Michael at Unison as well. And I would acknowledge the concerns that are being articulated. What I would want to make clear, however, is that the Trust has always been clear that any concerns that union colleagues have, they can raise with us, and any that they raise with us and provide us with even themes of, we will actively and directly address with ISS. And that's something that colleagues at GMB and Unison both did. And we looked into those in detail and have provided now, probably about a month ago, a detailed response, slightly delayed, as you might understand, during the COVID crisis. And it's important to be clear that while there were issues raised around pay and pay dates, issues in relation to the processing of annual leave, we sought assurances from ISS that these matters have been addressed, and indeed have noted acknowledgements from union colleagues that ISS's management and response to these issues have improved significantly in recent times. I wouldn't therefore articulate that there were or agree that there was evidence of really serious concerns there. In fact, often many of the concerns reflected the types of challenges we have as an employer in making sure that we always get it right all the time for the people that work for us. So I think it's really important to reassure members of this committee that we have had meaningful dialogue, active dialogue. We've not always been in agreement with the unions about how often we've talked and about the extent to which we've discussed matters, but where concerns have been raised, we've addressed those proactively and we've responded in detail and sought assurances. The final element I wanted to just say was that we remain as well in active discussion with union colleagues, and that's something that we are committed to continuing, and their views on the dialogue and the negotiations we're having with ISS have been something that we have taken very seriously and have taken into consideration when seeking to reach agreement with ISS on the final elements of the contract that Phil alludes to. Thank you.
Thank you all. I'm going to open it up in a moment for members. Can I just dive in on one area to start with and then open it up, and that's just on the occupational sick pay. Phil, you've given some possible encouraging words there that you might be able to work towards it. As I understand it, out of the 200 full-time equivalents, 100 are on or thereabouts. Half of them are on the old contract, which allows for proper occupational sick pay. And I understand, I think the Homerton is essentially there's a month's worth of sick pay, and then in month 2 it's a half rate or something like that. So we're dealing with 100 otherwise members of staff. I understand that your published sick pay rates as the Homerton generally is 3% prior to prior to COVID. And so just applying those 100 members of staff on London living wage on a 3%, I mean, I came to the figure of that it would cost you as a hospital around at most 80 to 90,000 pounds to ask ISS to provide full sick pay. Your turnover is, I think, now in excess of 250 million pounds a year. There may well be further reductions to that 80, 90,000 pounds because of reclaim from statutory sick pay. And presumably, if you say to ISS, we're going to pay for it, they'll give it. So the question is to you, bearing in mind the clear disparities that are there, and it's a basic right to be able to, and these are the people that are genuinely the key workers that have kept us going over the last few months. And I'm sure you have sick pay rights, and I'm sure the rest of the board and the executive team do. It's not a small sum of money, but comparatively, it's not enormous. Why can't you just say to ISS, you know, we're prepared to pay an extra £70,000. We'd like you to ensure full sick pay.
Thank you, Chair. So you'll appreciate I'm in something of a difficult position, which is not deliberately to try and then evade what you've just asked. I will try and do my best to answer that. But I am currently in the middle of a negotiation with ISS, and as much as I would love to tell you the deal is done and explain what that arrangement will be, we are not quite there yet. You've done some good maths. You're slightly out on some of your assumptions. It would cost something more than that, but you are correct in your assertion that the Homerton has a large revenue base, and this would seem on the face of it like a relatively small sum of money. If I could just take a few issues in turn. So Homerton's revenue is actually slightly more than that. It's about £340 million, but the trust overall is a break-even trust. The revenue position that you see in the annual accounts, as will be published and have seen previously, is supported by what used to be called the Provider Sustainability Fund, which is a bonus set of payments that are given to us for achieving certain performance standards, historically to do with A&E, but now in the last year, just our financial targets. That system has gone. So we are now effectively only a break-even trust. So while our revenue base seems large, our cost base is equally large, and our target this year is to simply break even as an organisation. So whatever we add to the cost base of the trust will present something of a challenge in terms of how we fund it, and will therefore necessitate us seeking efficiencies elsewhere. Those should be found, and that's part of the time it's taken to ensure that we can strike a deal with ISS that is appropriate. But you are right in your assertion that ISS will simply charge us for whatever we understand it costs. There is, though, a range of commercial aspects that we can put around what we are able to negotiate, which protect both the trust and give us all an incentive to ensure that this works correctly and appropriately. And one final point is just to say that the cost of this is no longer reduced by the government because of the statutory sick pay reclaim. That system of reclaim was abolished in 2015. So the government no longer funds organisations for statutory sick pay. It simply requires that organisations have those arrangements in place. So the cost of it will be the gross cost to Homerton. But that's what we're negotiating. And as I say, we are getting extremely close to being able to secure a deal. I am determined, as I know Tom is, as I know the rest of the board are, that the deal we strike recognises the work, the effort, the commitment, and the personal risk in occasion that the ISS team have put themselves to, working alongside all of us inside the NHS as full paid members, if you like.
Thank you. Councillor Snell.
Thank you. So in the letter we received from Tracy, she confirmed that no contract will be signed on the 30th of June. I'd like to clarify exactly where we are on this, because this current contract comes to an end at the end of September. You'll say you are still negotiating the detail of this new contract and hoping to actually improve it to London living wage levels and get the sick pay right. Can I just confirm at what stage you think you will be moving to sign? I mean, presumably you're going to get that sorted out before you sign any new contract. What the sign-off arrangements are, doing an equality impact assessment, because it doesn't seem to me you can do that when you don't actually know whether you are going to sign these frontline workers up to conditions that probably put their health at risk.
Thank you, Councillor. Tom may want to comment on the equality impact assessment. That's a piece of work that he will lead for the Trust. My expectation at the moment, given the current state of the negotiations, is that we will be bringing, without getting too boring about it, the standing financial instructions of the Trust require for a contract of this size that board approval is granted before it can be signed by Tracy or myself. I expect, given where we're at, and we've got a further small number of meetings to have, but my expectation at the moment and my planning assumption is to be bringing that contract to the board at the end of this month, which will be the 29th of July. Clearly, I will be recommending a contract to the board that I believe I can support, and you'll understand from what I've said what that will involve.
Councillor Swan, if I can just come back on the EQI point, equality impact assessment. So you're absolutely right. It's a question we've had internally as well. Our intention is to undertake an equality impact assessment, but we need to ensure that we are certain and have agreed the elements of the contract that are going to impact on the people that are employed by ISS. So once that's agreed, and as Phil's indicated, we're getting close to that now, we'll then undertake an equality impact assessment at that point.
And can I just check, if a recommendation is put to the board at Homerton, they would see that equality impact assessment, and would it be possible also to copy it to Health Scrutiny, because this is an area that worries us a great deal?
Absolutely, we'd be part of the conversation we'd have at board, and happy to review the opportunity to share that with you, or if not the full detail of it, to give you an understanding of the decision process and the review process that we undertook.
Tom, the equality impact assessments, are they normally in the public part of the board papers or the private part?
Truthfully, Councillor Hayhurst, I don't know if we've made the decision on that yet, if I'm honest. So I think we're probably going to review that. However, I know that Phil and I are clear that we want the final discussion around this to be, at least in part, in public. So I would expect it to feature in that discussion, even if it's not itself entirely shared.
Thank you. I've got. I want to go through members of the committee first. Then I have Councillor Gregory as well. So, Councillor Spence.
Hello. I wanted to ask the managers from Homerton about the contracts. Why it can't be bought in-house quickly. I mean, we've just spent the last 3 or 4 months under COVID-19 seeing the NHS respond very quickly and promptly to the pandemic. We're able to build Nightingale hospitals within weeks of this crisis. We're able to do many other things quickly and to short-circuit processes to bring about change. The second point really is about that COVID-19 has revealed huge inequalities within the NHS and within the workforce, as we've heard from the union officers earlier. And that brings me to my last point. I just do not understand why in the letter from Tracy Fletcher on page 10, it's stated that while you don't dismiss the in-house options for some facility services to be bought in-house, it's an option you're only exploring over the medium to longer term, and that and it says you're simply not in a position to undertake such work over the next few months. So I can't really accept that, and I don't think the residents of Hackney and the workforce at Homerton can accept that. That's essentially my point. I don't see why the Homerton cannot short-circuit the process in the present circumstances to bring this workforce in-house.
Phil, do you want me to take the first bit about insourcing, just wanted to allude to another organisation and perhaps let you come back on the detail of why that's a challenge for us. So I think it is. Understand the question. I understand, Councillor Spence, that observing the achievements that we made in London with the Nightingale as a collective NHS and across the country, it would potentially give one confidence that that's something that could be done. But it is important to understand that that was something that was at significant extra cost to the NHS and required multiple organisations to pull together in a way that was genuinely unprecedented. Any significant undertaking of that type was not something that we would be in a position to meet. The other thing to say is that while there is one other organisation in London that has sought to in-house at pace, I've spoken in detail to my equivalent in that organisation, and it's clear that the circumstances that led to that were meaningfully and significantly different to those that are faced by the Homerton. Not least that we have a service that delivers, or set of services provided by ISS that, by objective measures, have delivered to an excellent level for the patients that we serve and the people of Hackney during that time. I'll hand over to Phil so he can describe in a bit more detail why it's a particular challenge for us to insource at the pace that you're suggesting we should.
Thank you, Tom. I mean, and obviously I would echo everything that Tom's just said. I do want to stress, if it's not entirely obvious from all the discussions that have been taking place previous to this committee, that there is no ideological opposition in the Homerton to bringing services back in-house. Some of the challenges we face in the present time and in the very short term are simply entirely practical. As Tom's described, what the NHS miraculously did around Nightingale and others was done in a kind of there are no limits to what effort can be made to achieve it, including financial. We would not face the same environment when trying to bring these services in-house, and we would have to make sure they are delivered within the existing cost base of the organisation, and that there would be no support to the trust during any transition period. So we have effectively got one chance if we try to bring services in-house. If we get it wrong, that will be it for a very long period of time, I suspect. And what that means is we've chosen to make sure we take our time to scrutinise and make sure we identify all of the challenges that may exist to any future insourcing of these services, and to do that over the next couple of years in a really thorough, detailed way involving a number of different stakeholders. And it may still result in us concluding that that's not possible, but it's not a no forever. We want to have a look at these options and explore them in detail and properly. It may result in cost, and it may result in us understanding which services are just simply not possible to insource. For example, waste management is part of this contract. Some waste for the hospital needs to be incinerated. The trust does not have and cannot build an incinerator. So it would never be possible for us to fully bring all of this contract back in-house. But all of that dialogue, all of that conversation, all of that analysis is for another time, and to do thoroughly and in detail and properly, and to reach a considered view inside the trust and with the input of your committee chair and a number of people who've made comments already in the meeting. Right? So what we are doing is trying to secure the services of ISS at the Homerton with the standards that we've been delivering over the past few years for the next 5 years, to allow us to really thoroughly examine what the future options might be. And all of those options are available to us in the medium term, including remaining outside the NHS, but also to bring certain services back inside. All of those are available to us in the future.
If that's the case, Phil, why don't you put in a 2-year break clause into the contract if it's not already there?
Because, and that's a fair question, my judgment is that it will take us longer than that. A 2-year break clause means that we effectively would have to go to market for any of those services probably in about 12 months' time. And I honestly do not believe that I can be ready with a fully spec proposition in 12 months' time. I think I need more time than that. And I want to get any analysis that we do thoroughly scrutinised and done properly. And like I say, there's no fait accompli, there's no preordained end state. We need to look at all of the available options and do the options appraisal and analysis really, really thoroughly. And like I say, that could involve anything. Sorry, go on.
Is there a break clause at years 3 or 4?
No. No. It would simply result in a much higher price in the contract.
Okay. Other councillors who are on the committee. I know I've got Councillor Gregory there as well. I've got Councillor David. Kofi, do you want, we can't hear you. Do you want to change the audio? Still can't hear you, Councillor David. If I've got Councillor August Canley, and then I'll come back to Councillor David. Councillor August Canley. Dennis. All right, I've got.
Can you hear me?
Yes, I have. Over to you.
You hear me now?
Yeah.
Am I? Okay. Oh, thank you. Thank you, Chair. Firstly, I also would like to congratulate Homerton Hospital in achieving great rating, especially the key workers and all the hospital staff. It's an excellent result, and I'd like to relay my congratulations to everyone. I got a couple of following questions from the previous questions and also short ones, if I could just simply ask them. I have heard the concerns raised by the Unison and GMB, and that there are genuine concerns. I want to know why, and I also heard from Homerton Hospital that they are negotiating various concerns raised by the Unison and they were engaged with them. And I wonder why a short extension cannot be agreed at this stage whilst the pending negotiations can be resolved. That's my first question. My second question is about consultation with unions. I heard that unions were widely consulted and their views taken into account. I would like to know how this impacted negotiations with ISS and if that can be illustrated or giving examples. And thirdly, sorry, I want to come back on equality impact assessment and the timing of it. Once the contract is signed, and if there is an equality impact assessment with worrying findings, concerning findings, how will then that impact on the existing contract signed by the private company ISS? And what remedies will be available to Homerton at that stage? Have Homerton sought legal advice in relation to that particular issue? My last question is, I see an insistence on signing a private contract. I heard from those who represent Homerton that a break clause of 2 years is not achievable. How about 3 years? Would it be possible to have a break clause in the contract in 3 years' time when Homerton Hospital can work towards bringing the services in-house? And if the main aim of continuing with the privatized service is cost savings, and is it at an expense of the workers' right, which is quite concerning? Thank you.
Okay, so several sub points there. Who wants to go? Tom, do you want to go first?
Yeah, thank you. I'm going to do my best to answer all of your questions, Councillor, and then if I've missed anything or I don't cover something, fill in the rest. The first thing about a short extension, we're confident that we will have reached agreement on the remaining key areas that Phil alluded to that relate to the terms and conditions of ISS staff in the coming weeks. We'll also ensure that an equality impact assessment is undertaken before we sign a contract, and to give us the opportunity, should we need to speak with ISS again. There was one other element that you asked around consultation. I just wanted to be clear about this. So union colleagues have articulated that they wished to have a formal consultation. That isn't something that we agreed with, and indeed I'm not aware of there being a formal consultation for these types of contracts in my personal professional experience. Having said that, we do believe that we have undertaken meaningful consultation with them and dialogue with them, and the areas that Phil has alluded to that we believe we're close to agreeing in relation to terms and conditions do arise in part from the dialogue that we've had with, in particular, Unison, but also partly reflecting the conversations that we've had with GMB colleagues as well. So we have valued that, and it has had an influence, and it has been important that we've had meaningful dialogue. I should be clear, though, that that doesn't mean that everything that colleagues at the unions and representatives of ISS staff feel is important to address, we have felt we've been in a position to address. But there are some key areas that Phil's alluded to that we believe we are addressing, we want to address as an organisation, and we've been pleased by and benefited from the input of union colleagues in that. Phil, I don't know if you wanted to take the 3-year break clause question, although I would recognise it's similar to the question that we've had before.
Phil, just before you do, I mean, I suppose just building on Dennis's point on that, it would say your response was a minute ago to say it costs more. ISS will have built in a 15 to 20% profit base upon its contracts. You're shaking your head. I mean, they'll have built in some profit base on its contract by its very nature, and so there is a clear opportunity there of, if insourced successfully, that's offset against any extra cost it might be in the short term. But over to you.
Yeah, any break clause that's entered into a contract like this is effectively priced in as risk by the outsourced agent. I think that's a relatively well understood theme, and it will increase the cost of the contract. And as I say, any increase in the cost of this contract has to be found within the existing cost base of the organisation at Homerton, and that will require us to make changes elsewhere in the way we fund the services that we deliver. So ensuring that we deliver a contract that has the improvements that we have been negotiating and that have been represented extremely well by a number of people on this call, but also in many discussions before, and indeed that the board were cognizant of as we entered these negotiation processes, is we feel the absolute right path. I also just want to say in response to Councillor August Canley that this contract isn't a case of let it and then ISS are free to kind of do what they want for 5 years. We regard this as a tier 3 contract in our contract management practice. It means that it has the most significant level of scrutiny of performance, a contractual set of KPIs, and in some instances of the contract, some open book access to what's going on inside ISS so that we understand what they are delivering. We will be managing this contract to within an inch of its life, as we have done over the course of the last few years with the current contract, and making a number of improvements in this instance. And one of the areas that we have been insistent that comes to future performance review meetings is some of the features of the things we've been talking about around sick pay and performance management, and some of the other complaints that we have heard raised via colleagues like Naomi and Lorna and Lola.
Thank you, Phil. I'm already quite a bit over on this item, so I've got Councillor David who wants to speak, and then Councillor Gregory. I'm going to take both those questions together. Councillor Plouvier, I can't see you on my screen, but you haven't indicated as far as I'm aware. So unless you have a burning question, I won't take you. So Councillor David, followed by Councillor Gregory, please.
Okay, can you hear me this time?
Yeah, we can.
Okay, so I'll first start by saying congratulations on receiving the outstanding classification. I believe that outstanding grades would require outstanding staff, and probably your staff should be treated as such. I wouldn't rehearse all the points made, because most of the ones questions I wanted to ask have been addressed. But however, I will point out, I remember that you did mention about certain services which cannot be taken in-house. You mentioned waste collection. I have worked as a security officer before, so I know that certainly is not something you can say cannot be taken in-house. Now, people who do that work for long hours, 12 hours, 13-hour shifts. I'm sure you know that, you're nodding your head. So, I mean, I think that you have to give them some sort of consideration when you're taking these decisions. You've mentioned about the contract being like for like, and then talking about best value for money. If it's like for like and you haven't really considered the possibility of bringing things in-house, it might actually work out cheaper for you. I mean, I don't know about for all the other areas, but I know for security, you don't particularly need any, super, it's not really like rocket science where you need a very complex organization to get that. I understand the council is willing to provide some expertise if you do need that. So that's something that you might want to consider. Now, my question is similar to what Ben had raised initially anyway. What efforts have you taken to reach out for expertise, to experts for advice as to how you could go about insourcing specific aspects of the contract? So you're mentioning the waste collection is probably difficult, but then what about the other areas? And then why not stagger the contract like everyone else has said, so that you will have that option of being flexible to bring things in-house? I think that's pretty much it. But then the impact assessment, please make sure that's done. And I think that, I think you're rushing too fast, to be honest. So that's my question. What efforts have you made to seek expertise on those specific issues?
Councillor Gregory, can you come in with your question as well now, please?
Thank you. I'd like to ask Compton Hospital if you've undertaken a risk assessment of this contract. Because if you had undertaken a risk assessment, you would have identified the risks to Hackney residents, of whom 100 are actually watching this committee meeting this evening because they feel so strongly, and the risks to the staff of Homerton Hospital of having an employment a contract where people are not paid when they are sick. This isn't satisfactory. It's not good enough. We should not be issuing a contract where the risks haven't been identified for the benefit of all the workers and all the residents. I'd also just like to ask as well, you're talking about you don't have time to insource, but surely this isn't a surprise that this contract has come to an end and you need to look into options. You must have known. Why weren't you looking at this 2 years ago? Did it not come up on the board's agenda? So I'm just a bit concerned how it's been left to the last minute, and this puts you in a difficult position to negotiate as well. And I would also echo what others have said, perhaps a short-term extension, even if it costs you a little bit more, with a view to insourcing would be better. But my main concern is you don't seem to have considered the risk to the staff, all of the staff, and the residents of Hackney within the issue of this contract, which really concerns me in this current environment that we unfortunately all find ourselves in. Thank you.
Okay. Tom or then Phil, can I just flag? I mean, I've had other people indicating I'm going to have to. We're going to nearly be an hour on this item, so after this reply, I'm afraid I'm going to have to draw it to a close because we've got other significant matters to deal with still. But Tom and Phil, to reply, please.
I'll go first, Chair. If I'll take them in reverse order. One of the reasons, Councillor Gregory, that we haven't yet put a contract in front of the board is because we as a group of executives, I as the contract owner, with Tom's support, don't yet feel we have a contract that we would recommend to the board because of the issues that are being raised. So the discussions that are continuing with ISS are about addressing exactly the really important points that you have raised and seeking as best we possibly can to make sure that that risk is not realised in a future contract. So I totally recognise what you're saying, and we're working incredibly hard to make sure that the contract we are able to put to the board, hopefully at the end of July, does exactly that. But as I've said, all through the questions, we are absolutely not across the finishing line yet, and it's important that I finish those discussions with ISS with Tom's valuable input and get to a point that we've got a contract that addresses the things that are being raised with us, and we've heard and appreciate all of those. in terms of the effort to seek expertise on insourcing, we did undertake an options appraisal at the start of the discussions on this, and we looked at a number of options. We looked at some in more detail than others, but what I've said, and I'll say again, is it is absolutely our intention to be looking at the future of this contract over the coming months and years to make sure that when we get to the end of this new contract period, we have a full proposition that we can deliver safely for the trust. And as I said again, the absolute risk here about any insourcing option is that we get it wrong, and we have to spend a lot of money and a lot of time and put at risk a lot of hard-earned trust from the citizens of Hackney in Homerton Hospital. So getting it right first time, if that's the option we choose to take in the future, is of paramount importance. And like I say, at this point, for the future, everything remains possible.
And in terms of the point, maybe Tom, you could pick up, it dovetails slightly with Councillor David's point about outside expertise, and Councillor Gregory's about why didn't you start this process 2 years ago?
Yeah, so in terms of outside expertise, just to be clear that I've spoken at length and in detail with another organisation about an insourcing process they took at pace. I described earlier our learnings from that, and the fact that it's clear that that situation was fundamentally different in a number of important ways to the situation that we face. I also just want to make one other comment about risk. So we have an incredibly robust process for managing risk in our organisation, as you would expect, and that is an evidence-based process. So where there is evidence of concerns, we take those very seriously and we consider them. Union colleagues have been repeatedly clear that they feel they have concerns, and we invited them to detail those. It was a number of concerns they raised, and we took a period of time, partly delayed by the COVID crisis, as you might imagine. As a set of executives and leaders, we had to both manage that while looking into these concerns, and we provided a very detailed response. There was no evidence of the level of serious concerns that would have merited us considering those as formal risks within our very robust risk process. We provided that response to both GMB and Unison colleagues some considerable time ago now, and we haven't had a response from them on that, which leads us to be clear and believe that we've addressed those concerns. Equally, as Phil's alluded to, going forwards in any new contract, we are delivering what we believe is best practice management of RSS in the relation to people management, with a range of KPIs and seeking a level of evidence that will ensure that we're able to be confident that their management of their people is meeting the standards that we set for ourselves. So that was just one other area I wanted to come back on in terms of risk.
Thank you, everyone. There's a lot of going on in the chat. I mean, the thing is, if I let another round go back in, it needs another round of reply, and we're here in 15 more minutes, and I have got COVID on the agenda, plus the merger of the CCGs, plus the recovery plan. So I can't. I'm going to have to. I've already let this go over half an hour, and I'm afraid I'm going to have to. I know there's a lot of interest in this, but I have to draw it to a close at some point. So I am. Can we save the comments if possible? Can we cut and paste the comments in the chat so they're recorded, and then maybe they can be recorded in minutes or documented in other ways? One thing that's clearly come out is there have been possible indications of dealing with the living wage aspect and the sick pay aspect. So can we ask for, as soon as the negotiations have been finalised, an update on exactly what that is and whether it's parity with the other workers and the Agenda for Change contract? And can we also see, please, the equality impact assessment as well? And so those are my immediate requests following on from this. Can I thank everybody for this item? I'm sorry that we have gone over half an hour on it. So thank everyone for coming on it. And I'm now going to close this item and then move on to the next item on the agenda, which is respect of the recovery plan post-COVID. Those who have been here for this item, please feel free to log out if the next item doesn't concern you. So thank you. I'll give that a minute, and then we'll go on to item number 5 on the agenda, which is the Restoration Recovery Plan. And I think David Mayer, the Managing Director of City and Hackney CCG, you're going to speak to this.
Thanks, Chair. Yes. So colleagues will recall that we came last month and gave an update, well, certainly month before, and we also had the INL JOSC, where there's a pretty in-depth discussion on recovery and restoration across North East London. This plan brings together the partnership approach in City and Hackney across Homerton, our mental health provider, the GP Confederation and the voluntary sector. You will be aware that we are in phase 2 of what's expected to be a 3-phase process in terms of the NHS recovery from COVID. This plan sets out phase 2. We're expecting guidance on phase 3 to come in the next couple of weeks. Safe to say we remain in an emergency level 4 position across the NHS, which does define some of the actions we take are guided by national guidance, and as will become clear as I go through this plan, some very stringent infection prevention and control measures. Chair, there is a slide in the pack on reducing health inequalities. I'm considering the time and
which page is that, David?
Page 19.
Yeah.
I wasn't going to go through inequalities in great detail, considering last month's discussion on inequalities, but certainly we can pick it up in the feedback as we go through. But it is forming the very central basis of our planning locally. We've had a significant discussion at the Integrated Commissioning Board this morning, detailing some practical actions we can take, both to address some of the structural inequality issues, but also some of the immediate actions we could take around digital inclusion and those who are having difficulty accessing services in the current status of being mostly virtual, except for those who need most urgent face-to-face services. The plan is outlined over four chapters. There's an out-of-hospital service recovery, which covers mainly our community services along with our neighbourhood work. There's a restoration of elective work, which I'll talk through, which makes reference to North East London approaches to getting services reset in a safe COVID environment for both staff and patients. We've updated are in the process of updating our transformation plans. You'd be aware possibly in January, certainly January and February, I would have taken information on our long-term plan through Scrutiny, which we were gearing up to guide our work over the next 3 to 5 years, moving into a 10-year period. We're now going back to those plans, refreshing them in the context of COVID, and then resetting some of our transformation, including taking on board quite a refreshed look at inequalities, as I said, to centrally guide that work. And then the final segment, I think, brings us into the second item that you wanted myself and Mark to make a contribution to on the development of a North East London ICS and the merger of CCGs. So the plan on out of hospital in the main begins to look at resuming full service offerings across services, making sure that they're complying with infection prevention and control measures. Critically, I think at this point, although evidence suggests that we're not tailing up towards a second peak currently, but we are preparing certainly on that basis that we will see a corresponding peak, and indeed possibly a corresponding peak at a time of annual flu season through winter. So throughout this, you'll see reference to planning for resilience in the context of winter and further surges. Engagement with service users and communities is now resetting itself. The Integrated Commissioning Board has a comms and engagement enabler group, which has been meeting regularly during COVID. It's very strongly chaired by the Hackney Health Watch director, and is also led by a lay member from CCG. We are resetting our plans in that forum and revamping how we approach the format of engaging communities, particularly around Let's Talk events. So getting out and reaching into local communities using the neighbourhoods as the framework, and specifically applying culturally appropriate approaches in those environments, particularly in relation to translation of materials, which we're getting strong feedback on is a critical step towards managing services in equitable ways. There's a risk stratification approach on slide 23, which sets out the top end of the pyramid on hospital services, which I'll cover in the elective section. In the main, talking about out of hospital and care homes works, and then a segmentation of needs and complications running down to a lower risk wider population with indirect impacts of COVID, which we have some plans in place to address, which you'll see throughout. The next section talks about restarting elective work. As I mentioned previously, this is an enormously complicated exercise, not least because many of the diagnostic procedures can be deemed as being aerosol generating, and thus that puts a pressure on getting people onto safe pathways across Northeast London. There is currently work happening across our acute and mental health providers to join together in an alliance type format to set out ways that they can reset services within the health campuses across Northeast London. That is still very much work in progress. The expectation is that we would continue to see Homerton deliver expert surgical services for gynecology and indeed general surgery, but there are discussions happening at a clinical level about how we reset orthopedics, ophthalmology, ENT and urology as a partnership across Northeast London, and I hope in due course to be able to bring further information on that elective work back to Scrutiny colleagues and health and wellbeing boards over the coming weeks. That, as I said, is a complicated exercise, but I feel reassured from early indications of the discussions on that we are well placed in City and Hackney to use our neighbourhood model to adequately meet people's needs in advance of them needing an admission, bearing in mind that often the decision to admit is the most complicated decision clinically. So ramping up our resources at a neighbourhood level, using our secondary care colleagues to work at a neighbourhood level in a newly formatted model around primary care networks, I think is a really optimal and progressive model for out of hospital services going forward, and in many ways has been expedited by COVID.
Can I ask you to wind up, David? Thanks.
Okay, sorry, that's first. So there's an integrated delivery plan on through the rest of the document on page 29. The functional areas of that cover children, young people, maternity, neighbourhoods and communities, rehab and independence. I reference those because we've obviously got integrated work streams in place. I think these three broad headings are probably likely to form the basis of our integrated work programme as partners over the coming months. I won't talk about the neighbourhood multidisciplinary team, but as I said before, and I re-emphasise again, the neighbourhoods really are critical to this next phase of our work in City and Hackney, and we stand proud with Homerton and Alfton GP Confederation and the voluntary sector in bringing this to life with our local authority colleagues, because I think it is going to be fairly central to how people experience good healthcare. Inequalities is outlined on page 18. I mean, Ben, I was going to go through the phase 2 governance in terms of a local integrated partnership and try and bring the 2 agenda items into kind of a bit of a flow, but I'm happy to break now.
Let's break if we can. I want to maybe just still treat the integrated thing as a separate issue. And so we could take questions now just on the in particular on the recovery plan. Members, are there any questions from members at the outset? Councillor Snell.
Well, the first area of concern, I might as well ask 2 together, it's quicker, was just where you got to, which was in terms of reference of the SOC. I never understand why you invent all these long names, but anyway, the SOC, whatever it is, what slightly worries me about this is it appears to be all people working within various aspects of the local health economy. So I'd like you to explain to us where the engagement is with, Healthwatch Hackney and organisations like that. This seems to be very much professionally led rather than community engaging. And I mean, I'm leaping right on, but I am confused because a month ago we were told that the reason that we didn't end up having to use the Nightingale Hospital is because in treating COVID, often, there were complex multiple morbidity issues, and so you couldn't really separate out COVID-19 cases. And in fact, my understanding generally in a surgical setting, up and coming doctors need to be exposed to a wide range of circumstances so they can learn to each other. So can you explain to me why all of a sudden we seem to be setting up COVID specialisms when in fact the evidence, I thought, was that they weren't really very helpful?
Thanks, Councillor. I'll ask Mark to answer the second, provide some input on the second question, but I mean, there are deeply complicated issues about configuring hospitals so that they can operate both in a COVID way and also in a non-COVID way to provide care for people. But I think Mark may be able to make a contribution there. The System Operational Command is not our language. This is national language, and the directions that we received from the NHS were that those command structures were to be led by community providers. In the context of City and Hackney, that's the Homerton, which so Tracy Fletcher chairs that group. It was set up to act very, very quickly in terms of supporting people to be discharged from hospital into safe settings in the community, and to then create capacity in acute hospitals to manage what was then expected to be significant numbers of patients. So it is set up in a very, very operational doing way, which is why the membership looks as it does. We are now going into another phase of redesigning that, which I think will begin to pick up some of your concerns about wider engagement and build membership around communities in a much clearer way. You'll know Vanessa Morris has been providing some input from the CVS on this group, which has been hugely helpful in terms of making sure we're linked into the humanitarian network. But yes, correct. Safe to say, this isn't the model for the future. This needs to change, and we're in the process of going through the thinking on that now.
Just David, on that point, I mean, has it taken over the integrated? It almost seems like it's taken over sort of like at the moment the key, and I can understand why in the shorter term in COVID emergency it needed to, but it's almost taken over all the sort of control functions of the integrated commissioning board. I mean, in the medium term, are you obliged to keep this structure? I mean, how soon are we going to go back to a more collaborative approach where we see local authority input, Healthwatch inputs?
I mean, I have to say, local authorities are part of this. So Simon Gadzinski and Chris Pelham from City and colleagues. I mean, this is quite an integrated model in itself. But as I said, recognising Councillor Snell's comment about it being not hugely representative to the wider community, has it taken over the Integrated Commissioning Board? Well, in the sense that commissioning from CCGs has to all extent and purposes been suspended by the NHS in this period of COVID. NHS England has taken over most of the commissioning powers. We are now paying for our provision of health services on block contracts. We're doing that under instruction from national colleagues. So to an extent, in a commissioning sense, much of commissioning has been paused. So we are actually responding to a set of jointly developed plans through which the SOC develops, which we are now putting through our Integrated Care Board and indeed Scrutiny, which is the point of it coming here. So the plan should be viewed as a live document, and the engagement on it is part of what this discussion is intended to achieve. So it shouldn't be viewed as just a still. It is an emerging, evolving framework. In terms of the leadership model, I mean, I think that is probably something we'll pick up in the next question, because there is a debate that we are now having across the partnership in City and Hackney about how we take the best bits of the System Operational Command, which got a lot of things done very quickly, very safely, and still maintain good quality outcomes for patients and our residents, taking the best bits of that model and hardwiring that into the next chapter of our work as a integrated partnership in City and Hackney. So that is a live discussion. And I think, as Councillor Snell referenced, we would want to see local authorities really, really hardwired into that, which is something we've discussed before, particularly around the work streams and making sure we bring local authority involvement and social care involvement to the front.
Mark, do you want to deal with Councillor Snell's second point in terms of this distinction between COVID, non-COVID, emergency and elective? I mean, I'm sure you're aware of Dr. Gary Marlowe's letter setting out a number of concerns in relation to that, and I can understand a lot of the logic of his concerns about how you can't have a COVID and non-COVID world that simply doesn't exist with asymptomatic people, and in terms of sort of trying to reorganise hospitals around emergency and elective. Things Councillor Snell's talked about in terms of you're losing from cross-training from each other. Presumably there'll be issues about viability of A&Es if you haven't got a breadth of surgical support behind a particular A&E. Can you address some of those issues?
I mean, it's there's an awful lot there in your questions, and to do really thorough justice to it would take quite a long time. But I think that going just back to the Nightingale piece, and then I'll go on to the elective piece in a moment. The Nightingale hospitals were being designed for a time in the pandemic when we were expecting or being asked to plan for the shape of the curve to be a lot worse than it turned out to be. We were thinking at the time that critical care across the NHS would be overwhelmed. So therefore, the resources were literally thrown at these Nightingale hospitals in order to get them up and running as fast as possible to take over critical care. Two things happened, which is why they weren't used that much. The one in London wasn't used hugely, as we know. Two things happened. One was the critical care bed capacity within existing hospitals was ramped up incredibly effectively, and there was huge changes within hospitals. So all wards had COVID patients in. People realised that actually with high oxygen therapy, fewer people needed to go into A&E, go into ITU. Those that did go into ITU, all theatre staff, all anaesthetists, everybody was just upping the capacity, and that worked very well. It was also found those people in ITU invariably, as Councillor Snell said, became very ill. They became very ill with renal dysfunction, with blood clot problems, with all manner of other problems other than just plain respiratory problems. Now, the ITU beds in the Nightingale were really kitted out to help people with respiratory problems and ventilators, and they weren't skilled up with the staff and the kit to deal with these people who were really even much sicker. Now, all this stuff wasn't known when the Nightingales were being planned initially, because we were catching up trying to understand the condition. So there's a lot more to say about that, but that's in essence what happened there. Now, going on to the sort of piece about the elective care, you're right, you can't guarantee somebody doesn't have COVID. What you can do is reduce the likelihood that they would have COVID. Now, that can be done by testing regularly before somebody comes into hospital, by screening when they come into hospital, taking the temperature, asking lots of questions about who they've been in contact with, etc., etc. And so you can minimize that risk, because we know that people who and there's been a lot of research shown that even people who have relatively routine surgery, a gallbladder removal, they suddenly contract COVID as part of their time whilst they're in hospital. Their outcomes are much worse. They get much sicker. So you've got to try and minimize this chance, but you can't eradicate it. But it is important to minimize it. Otherwise, you're going to have far more people contracting COVID in these situations when they're just coming in for elective care. So in order to do that, this splitting of surgical activities, orthopedics going on here, urology here, gynecology and general surgery, which is mostly sort of all manner of other general stuff that doesn't fit into any other categories, will be going on still at the Homerton along with bariatrics. The training, it is a real challenge around training and rotas and how that'll be fit, how that'll be organised, and it's it's proving, a great challenge, but it isn't impossible. Surgeons rotate, and they will just rotate quicker. They will have to rotate quicker to get the proper experience, and that's what they do. They usually rotate every 6 months or so, or whatever their rotation might be. Now they're going to have to be moving from different units. Now that has, that will have impact on the quality of their training, and that needs to be addressed, is being addressed. You could say this isn't the perfect way of designing a health system if you didn't have COVID. Well, it probably isn't, but we do have COVID, so we have to work with that, because the consequences of getting COVID as part of a routine operation is, as I say, very, very poor. So I think all of that is that there's a lot going on in that space, but because you're going to try and minimize the risk of COVID, it does require these pretty dramatic changes.
Okay, Councillor Spence. Thank you, Mark.
Yeah, hello. I wanted to ask about the reference to population health outcomes in the document, where you've made reference to that on a number of the pages, and how that relates to health inequalities, which again is sort of referred to throughout the document. But that then also leads me on to a question about the governance. And it might be a naive question, this, but I can't see any reference to public health departments in Hackney and in the City of London, and what input you might be looking for from public health colleagues in addressing the population health outcomes and questions about inequality. Because it seems to me that public health doctors do have a particular expertise in those areas, and it's not clear to me from the terms of reference on page, I think it's page 32 of the bundle, that there's a public health representative, but I might be wrong about that.
There's some reference to it on page 37, Councillor Spence, but I'm giving you priorities. But who wants to, David or Mark? Who wants to?
I just want to. So I'm just trying to distill the question into so population health and how we see that playing a role in the inequalities agenda, and then.
It's particularly. Sorry, should I come back? It's particularly about public health and the input of the public health services. And I'm mindful also of the backdrop to this, which is again COVID-19, where we've had central government largely, it seems to me, sidelining public health services in local authorities in terms of managing the pandemic. And my reading of this document is that I can't see much reference to public health.
Well, that is an error. Public health are firmly part of this this work. Jane Taylor, who is one of Sandra Husband's consultants, is a key member of the System Operational Command Group. Jane's leading a large piece of work on inequalities with the CCG. Anna Garner, who you know, Sandra Husband's chairs a pandemic leadership group, which I attend and feed through from SOC. So there is a strong, and I think it's a tribute to our integrated working that we're able to join things up in the way we have done. And yeah, if that's not clear in this document, then it will certainly be clearer in the next version you see.
Okay. Thanks for that, David. Just before we come on then to sort of the what's going on with the sort of CCG merger, as it were, do I have any sort of, take one more question if there is one from any member in terms of this recovery plan, or shall I go straight on to the CCG merger? Okay, I'm not seeing any. Okay, CCG merger, David, I mean, if it wasn't for COVID, you would be coming back to us this month with where you were on consulting your GP membership base for folding the City and Hackney CCG and moving into a single STP footprint CCG, and then the plan was to have 3 systems with under that. So has this all been paused, scrapped because of COVID, and we're now under this SOC system? Where are we?
So it has been paused. That doesn't mean that the time frame or the time scale has changed, but active work on it did pause during COVID for obvious reasons. I think it's fair to say, just stepping back from it a little bit. I mean, I've been operating as in the Gold Command structure at North East London, and I also take a leadership role for end of life care, mental health, and out of hospital care. So I do, in my day job, I sit both looking in at City and Hackney and looking out from it. And I have to say, in many ways, how North East London has responded to COVID is, in essence, an integrated care system in action. It has involved all provider partners coming together across North East London to do planning. It has involved, I think increasingly will involve a greater sense of ownership from local boroughs in terms of their relationships with the health service across North East London. So the ICS in many ways has been operational during COVID. And I just wanted to just make that plain in terms of bringing some life to the spectre or the omen of there being a North East London ICS. It's here with us and is operating now. What that practically means for the CCG, I think Mark and I are continuing or have restarted, I guess, with earnest our engagement with members locally. We had our clinical exec this week, which brings together our GP leaders along with the primary care network directors to talk about exactly this topic. How would we enshrine the best of what City and Hackney has? And I have to say, as I share the accolades that colleagues have passed on to Homerton, and they're well deserved, and Mark and I have extended them separately, I think we are novel, possibly in London, if not nationally, as being an outstanding CCG, an outstanding acute trust, and an outstanding mental health provider, along with a suite of outstanding services from our local authorities. So we are approaching this very, 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 very mindful of the building blocks that we have in place, the genetics of the City and Hackney system and partnership, and absolutely nailing those into a constitution and a set of words which enshrine them locally across the partnership that we've built. That will be a critical part of the next 3-4 months work that we do as part of that move to a single CCG.
And so when do you propose to go to your membership to say vote on dissolution and reconstitute as a single STP CCG? What's the time scale now?
No later than mid-November is the current expectation from regional colleagues. Mark and I would expect that we would be having a series of preliminary conversations with them right up until September, and we would be taking a view certainly in October that we would be seeking to get a vote on a constitution that they could support.
So, second point, David, just to try and get clarity on this from my perspective. I mean, some of the issue when we were discussing this previously pre-COVID was where the money flows would be. Typically, whatever the £400 to £500 million has come towards City and Hackney CCG, that's then gone out to the Homerton. You gave either 10 or 15% towards the STP for sort of services that were better commissioned at that level. When you came before us last, you were talking about essentially the money all going up, but getting 80% down, so giving 5% more up for commission services, but the bulk of the money still coming down. Where are we with those money flows? And I also just say this in the context of, because of the demographic weighting of the funding formula. I mean, I'm not saying Hackney's well off, but it hasn't done badly out of the funding formula. And if that doesn't necessarily continue, some of the building blocks you've described might not necessarily be here in 5 to 10 years. So where are we on that 80 to 85% of money on that demographic funding formula still coming to Hackney?
I think, in all honesty, I think that's going to have to be part of what we bring to members to agree. That's work that's been undertaken now. There is talk, I believe, within the NHS structures of allocations for next year being given at an ICS level for then to be distributed across the health system. Our expectation, which we've talked about repeatedly, is in essence, as you describe, an 80-20 ratio of resources that we believe would be needed to maintain good health outcomes in the Hackney place. That would continue to be our priority. I continue to work on that with colleagues at North East London, and I know Mark continues to push that with Chair. So I can't give you anything more concrete than that at this point, Chair. But it is work in progress.
Right. I mean, all I can say, I mean, I'll let members come in now. I mean, all I would say is sort of from our perspective in terms of a sort of governance and assurance point of view and a scrutiny function. I mean, if that isn't being maintained, it's a greater level of alarm bell for us, because there's a clear medium-term risk for what we've achieved in Hackney not being here. So,
can I just say, certainly it's Mark again, just to say that in terms of constructing a new constitution with all appropriate schedules outlining exactly how this is made meaningful, you know, this isn't going to be a PowerPoint presentation, members will be voting on. It'll be something which is as legally binding as possible in the context, you know, bearing in mind, even now, the world we live in at the moment as a CCG is still, you know, NHS England can still come in and come in from the left field and demand all sorts of things. So, but we will have a constitution written illegally. And if you were to have that question to, say, Henry Black, CFO for the STP, he would give the same answer as David just did. You know, and he would, and if I spoke to Henry Black, he'd give the same. James, the other chairs would give the same. So we've been working at this for a long time. So the narrative collectively is actually really, you know, the words, people speak the same language much more these days than maybe 18 months ago, whatever it would be. So, but we then have to get that into a constitution, which we can then go right, and we can pore over and go, this is right, okay, and then we move on with it.
Fine. I look forward.
Now we'll have another one then, but you know,
fine.
yeah,
right,
exactly.
I look forward to hopefully seeing a draft of it.
Lots more late nights, I think.
Before it's agreed. So, I mean, it would be a request for us to see at a stage that's not too late to be able to meaningfully scrutinise it, exactly what is being proposed. But it looks like we're talking October, November. Other members, questions on this? I'm not seeing any. Okay, if there's nothing, is there anything else for David or Mark on the recovery plan, what we've seen, or shall we go on to the next item with Dr. Sandra Husbands? Okay, so next item with Dr. Husbands in terms of the COVID update of where we are, please. This is item number 7. Thank you, David. Thank you, Mark. We haven't forgotten you're an outstanding CCG as well, and you're part of that story, and you both individually are as well. So thank you very much. Dr. Husbands, can you just give us a broad overview of where we are currently? When you emailed me, I think last week, you said in the week prior there had been 3 cases in the last 7 days in City and Hackney from Pillar 1 and Pillar 2 testing. Where are we this week? Is it still that low? And how's the test and trace working?
Thank you, Chair. So this week, in terms of the number of cases, there's been a slight uptick, as we say. So we had about 7 cases in the last week, which puts us into a position where we're very closely scrutinising that to see whether there's a more general issue or whether it's just because we've started from a low base. It looks like a significant increase. But that also included a small cluster of cases related to a particular setting, and so the fact that there were a few is not necessarily unusual in that context, and so it may not necessarily represent wider community spread, which is what we're aiming to avoid. So we're just keeping on top of that. The good news is, and thank you to the people of Leicester, although I'm very sorry for what's going on there, partly because there's been that continued outbreak. Actually, it's not like it's a new thing. It's just that they never had the fall in numbers of cases that everywhere else in the country had. You know, as Mark described earlier, that we'd had a peak of coronavirus cases and then it'd come down, and we're kind of bumping along the bottom at the moment now with relatively small, you know, 2, 3, less than 10, sometimes none in a week, numbers of cases. And in Leicester, they just never went down. But that issue and the publicity associated with it has meant that at national level and with partner organisations who have the information but who haven't been sharing in the detail that we wanted, and we had quite a discussion about that last time, everyone's now looking again at whether local authorities are actually getting what they need in order to be able to understand the context. So we're not asking for all the person identifiable information about people, but if you just give us a whole load of numbers with no other context, there's nothing we can do about it. And so there's an issue. There was the issue in Leicester about whether they were getting all of the data from Pillar 1 and Pillar 2, meaning basically that the tests are carried out and managed in different ways, and it doesn't really matter what those two things mean to everybody else outside of the Department of Health, but that also means that the data are collected separately. And in London, actually, we've been getting the data from Pillar 1 and Pillar 2 testing all along, but outside of London, they weren't getting that, and that was one of the issues that they had there. So, but having said that, we're now getting more detail. We're going to get even more next week. So there have been some changes, and there's been a lot of work done since we last saw you. So in terms of where we are with the epidemic, still low numbers, still not any great cause for concern, but a lot of work has gone into developing our local outbreak control plan. This has been happening across all of the local authorities, and we have a joint one with the city, of course, and ours was published at the end of June, as they all were. It's a dynamic plan, meaning that it's going to be updated and amended as new information comes to light. So at the time it was published, for instance, there was no real clarity about the powers that existed for local lockdowns, but we were expected to put something in the plan about local lockdowns. Since then, of course, Leicester happened. So there's been a lot more discussion and a lot more clarification about what those powers are and in whom those powers are vested. And we'll be able to update the plan. And in fact, I came from a live exercise this afternoon, London-wide exercise with various organisations, including Public Health England and the police, about what the scenario might be where we might need to consider a local lockdown in London, and what powers we had at local level and at national level, etc. So there's more information and more evidence. As Mark said, we don't know that much, or we're learning all the time about this virus, so more evidence will come to light, and we'll keep amending the plan to reflect what we now know and what we need to do in light of what we now know. And then since it was published, we've been focused on producing a number of standard operating procedures, which are to help, which are focused on specific settings like schools, care homes, religious places of worship, workplaces, etc. And the purpose of these is that the people who manage those settings know what they need to do, both to keep their place safe in terms of infection prevention and control and managing people within it, but also what to do if they are aware that there's a case, somebody who's infected who is there or has been there, or and in particular if there's more than one person. So they know, so they need to contact Public Health England, they know to contact us, and that we can provide them with support. And it picks up, these all pick up where the standard operating procedures from Public Health England leave off, so that there's no gap, and we're really providing sort of seamless support at local and regional level. And then in terms of the data dashboard, one of the key elements of the plan is about collating the data that I spoke so much about earlier, and then presenting it in a way that is useful to policymakers and planners and people who need to take action, but also presenting something to the public so that they can have an understanding of what's going on and be reassured that not only do we know what's going on in terms of the local epidemic, but that that we're doing something about it. So I can't show it to you, I'm afraid, because I don't have it. But we have a kind of alpha version of the dashboard that's been developed by our principal public health analyst, Diana Divieva, and a number of you I know have seen it in other meetings. It's coming along really nicely. We're hoping that over the next, well, we're planning that over the next couple of weeks we're going to be able to not only refine that, but also test it with various stakeholders, including members of the public and patients, so as well as partners, etc., so that we can make sure that both elements of it, the public facing bit and the sort of more professional facing bit, are actually fit for purpose and doing what they say they are going to do. And then the other thing I wanted to update you on was testing. So when I was last here, I talked about the fact that we had been exploring with Barts Health whether they were going to be able to provide the laboratory support for some local testing. And how that's working is that we're working actually with our North East London STP partners on this. And so we are a seamless system, as David was saying earlier on. And so there's some capacity to do some local testing, but both in terms of what we might be able to do through the STP in terms of providing kits, and also in the laboratory, the bottleneck or the limiting factor is that there's an international shortage of the reagents to do these antigen testing. You've probably heard this on the news several times. It's actually true. It's always been true. But what's happening for us is that the supply of reagents is controlled nationally. So it's being procured nationally and it's controlled nationally. And so we can only get so much for each lab. And in order to do the level of testing that we wanted to scale up to, that's outside of the regional test sites and mobile testing units, to do our own STP thing. Barts wouldn't have been able to get sufficient amount of reagent to do that. That doesn't mean that we don't have any other irons in the fire. So one of the opportunities for us is that Queen Mary University is carrying out a trial and it's a trial of basically using a different approach to processing the tests. And they would like to enrol all the care homes across North East London in it and work with our GP practices on it as well. And that's one really good opportunity. And then the other thing that's happening, again, because of all the dialogue, and I suppose this is one of the benefits, I guess, of being part of the Good Practice Network, is that we've had the opportunity to feed back up to national bodies about the limitations of the way that things have been provided and designed up till now, why they're not working for us and how we could make them work better. And one of the things that they are being very much more flexible about is testing, is access to testing, and they're recognizing that actually lots of people aren't accessing tests because it's difficult. So they not only are in London and nationally scaling up the number of mobile testing units, so there's going to from 9 to 15 in the next couple of weeks, and the frequency with which they come is also going to increase, so the testing is going to be much more available. They're also giving us the opportunity as directors of public health to be able to direct to a degree the deployment of those mobile testing units, particularly in the circumstance where we have an outbreak or are concerned about an outbreak. So it might not be an actual outbreak, but we might have a cause for concern, like there's a particular premises where you've had a cluster of related cases, and it might have all of the right conditions for there to be a significant outbreak there, and so it would be a good opportunity to deploy the mobile testing unit and test everybody, at say an you know, a factory or a warehouse, or, you know, those sorts of premises. So there have been a number of developments, both at national level and local level. Lots of hard work still going on.
Thanks, Sandra. That's an incredibly valuable and comprehensive update with lots of really useful information. Thank you very much. Members? Councillor Snell?
Thank you, Sandra. I just wanted to really ask questions arising from the last one of these meetings, because I was reading the minutes before tonight and it refreshed my memory on what the issues were. So the one issue, and they complained about it in Leicester, and you've not said 100% it's sorted, which is that we get figures for people testing positive, but we weren't getting full address and contact details on pillar 1 and pillar 2. So the starting point, because if we're going to do anything, that has to be the starting point. And then, of course, you're referring to improved cooperation over testing. But one of the things that was said at the last meeting by Professor Costello was, why aren't we enabling and empowering our existing frontline physicians, i.e. the GPs, to actively be able to refer cases and even take tests themselves? Now, has there been any movement on that whatsoever?
So I'll take the last one first, and the short answer is no. And I can't really answer the why of that, but the short answer is no. I came from another meeting with the Department of Health and Social Care lead on testing this afternoon, where he was talking to us about all the ways that things are changing. And one of the ways in which things are changing is that they're standing down the army. So I took the opportunity to say, well, why not, instead of giving it over to private contractors, why not just take the opportunity to do something completely different? Because you might need a different model. He didn't actually answer that question there. And then your first question about whether we get names and addresses, no, we don't. And it doesn't look as though that's what we're going to get.
But Sandra, how does that work with you saying before that of the 7 in the last week there was a cluster? How do you know that if you haven't had names?
Because I know that they were related to a particular setting. I'm just not telling you all of the detail because I don't think it's appropriate.
No, I'm not asking.
But I know that there was a cluster related to a particular setting.
Sure, I'm not asking for details, but I want to know, how do you? I'm just trying to.
How do I know that?
Yeah, how do you know data thing if you're not getting name and address?
Okay, so this is Public Health England's argument, which is that if there's an issue related to a complex case or a complex setting, like it's a school or a care home or something, they will notify us. But also, what we do get is postcodes. So you can actually see if you get several cases that are related to, because it's a full postcode. So you don't get the whole address. So, you know, it could be the whole street, the whole side of a street, couldn't it? And it could be a tower block. But at least you know. But the likelihood is that if you get 4 or 5 that are related to the exact same postcode, that it's the same household. Yeah. Especially if there's a spread of ages. And we can always just check that with Public Health England. But if there's a school or something, they tell us.
So there's a setting, they tell you. If otherwise, you are getting full postcode data, so you can make assessments as to whether there's a cluster or not, depending on similarity. Thank you. Councillor Spence, did I see a question from you?
Yeah, hello. I wanted to ask, can you hear me?
Yeah.
Yeah, I wanted to ask Dr. Husbands about the, because you talked about the sort of testing regime, but the sort of the follow-up to that is the tracing and isolation of people who contact tracing and isolation. And what's your sense of how that's panning out so far in Hackney and perhaps in, London? What's your impression and observations on that?
Well, I do get data about how many cases. So it comes as a report, which is mainly, it's kind of a performance report, if you like, about the test and trace system. So it tells you how many cases there have been, how many have been completed, meaning they've been contacted by the contact tracing system, and then it tells you how many contacts have been contacted by the contact tracing system. So I'm able to, how many contacts have been identified and how many have been contacted. So I'm able to see what the performance is in terms of in percentage terms, and it's probably about somewhere between 50 and 75% from week to week, that of the number of cases that are actually 75% of cases that are contacted within the 48 hours, and probably 50 to 75% of contacts that are followed up. And whether that's because they either ran out of time, because if it goes beyond 48 hours they don't bother contacting them, or because the index case people didn't give real information about their contacts because they actually don't trust the system. Who can say? We don't get any of the detail about who those people are, we just get those numbers. In terms of how that's working, I would say that the performance percentage is probably not as good as we would get from normal, non-emergency, non-COVID times contact tracing by Public Health England professionals. But then partly they're more used to it, I suppose, and they're better trained, they're more used to it. And we do know that there are gaps in the data. So Public Health, NHS Test and Trace does produce these data reports. It's they put all the information into a web tool and it produces these data reports. And so they're supposed to collect information like where do not just their names and addresses, but where do they work, what their ethnicity is, and various other things that would help us be able to build up a local picture, and would also help Public Health England be able to tell us that we've had 20 people and they're all of Turkish origin, so maybe there's something going on. But if they're not collecting information effectively about their ethnicity or their their places of work or whatever, they can't associate them with those things, and so that is a problem, and that is an issue at the moment with Test and Trace. They're apparently not collecting that data as well as they should. That's Public Health England is on top of that, and they're feeding that back and going back to they're not in control of that system. It's run by Department of Health, or I should say commissioned by the Department of Health, but they're feeding that back to the Department of Health about the difficulty that it puts us in at regional and at local level, not having that information. And again, I think it just goes down to the inexperience of the call handlers. Some of these are sensitive conversations, and it just takes a while to learn how to do this. It's probably easier for some than it is for others, but what that means in percentage terms, I don't know.
Thank you. I do want to finish by 9, so I've got a few minutes left. We need to do the election of the vice chair. Are there any other questions from members? I'm looking. I don't.
Yes, please.
Councillor August-Canley.
Thank you, Chair. Just a quick one, follow on question about tracing. I have spoken to a local business owner, a coffee shop owner. He told me that he was told to keep a record of everyone who was sitting in his coffee shop, but and then he showed me a list, but there wasn't a timeline on the list in terms of who was coming in at what time. For example, there could be someone arriving 6 o'clock in the morning, and then there could be someone attending the coffee shop at 4 p.m. in the afternoon, and those two people would never kind of see each other or interact with each other. But nevertheless, they may get a call saying that you have to isolate. That seems to be a flaw in the system, unless there's lack of education and understanding of how those data should be kept. Is there anything that is being done to address this issue? The other concern is, I understand some people are refusing to give their details and therefore refusing to attend those places. Obviously, there's a fine balance of protecting health and individuals and also trying to support our small businesses. Can I have your comment on those issues, please? Thank you.
So to comment on your first point about information not being kept in a way that's useful. Public Health England actually produced a toolkit for small business owners so that to help them with exactly that, which we plan to disseminate. So it's an online one, so I don't. I'm not sure how exactly we're going to disseminate it, but we'll start with our business networks and then see what else we need to do to make sure it gets out to people. But it basically tells you how to do it, how to keep the information, how to maintain people's privacy while keeping information, etc. And all you need to know about keeping people's information really for the purposes of contact tracing. And then your second question, yes, there are people who are going to refuse to engage, and that's one of the key things for us, well, actually across the whole of London, is that there's a combination of both ignorance and distrust of the system. And we are working with our community and voluntary sector partners to help get the message out, educate local people, and also rebuild some trust in the system so that people can engage with this in a way that they understand it's actually about keeping themselves and their families and the communities safe and free from the virus, and not about collecting data to be used for nefarious purposes.
Thank you. I see Councillor David, this is going to be the last question and then we'll wrap up. Councillor David.
Yeah, it's not really a question as such. It's just to say, commendation. I understand that there were some people who had booked for tests and they got it and got their results before 48 hours. So I think that's good. I mean, the tracing might be a problem, but at least I think, just to commend you on that bit. Yeah.
Thank you.
Thank you. I'd like to claim credit, but I can't really.
Thank you, Dr. Husbands. That's incredible. That would have been incredibly useful for the update. We appreciate it. And I imagine we don't have a meeting in August, but I imagine we'll ask you back in September for a similar update as well. With that, can I draw this item to a close, and then we're nearly done in terms of drawing the meeting to a close. There is the election of the vice chair. So from members of the commission, can I have a nomination, please?
I'd like to nominate Councillor Snell.
And a seconder, please. Do I have a second?
I'll second.
Councillor Pluvier, thank you. And then are there any other nominations? And then in that case, are we all agreed that Councillor Snell is elected vice chair? Great. Thank you. Thank you very much, everybody. So that's formally been done. Minutes of previous meeting, item number 9. We take those as read. Jarlath, minutes. Thank you. Work programme is number 10. I think my preference is still that there's matters still in discussion, still to keep a degree of flexibility in terms of where we are with the COVID situation. I think it's clearly we probably want Dr. Husbands back for a further update in September to know where we are. But I'll touch base with members following conversations with Jarlath as to where we are with that. I think the benefit obviously is trying to keep it quite topical in terms of what we've seen with the ISS contract and COVID, and so try and maintain that pattern. And I haven't been notified of any other business. So with that, I will thank everyone and draw the meeting to a close. Thanks all.
Thank you. Good night.
Thanks all.
Thanks.